Welcome to the latest in our series of TopMedTalks 2. In these podcasts, the TopMedTalk team is in conversation with global thought leaders in perioperative care. TopMedTalk.
Hello, I'm Desiree Chappell, and this is Top Med Talk. And we are privileged to sit down with Dr. Frances Chung. Right now, she is an anesthesiologist and professor of the Department of Anesthesiology and Pain Medicine at the University Health Network and University of Toronto. She's also the ResMed Chair of Anesthesiology, Sleep Medicine at the University Health Network. Dr. Chung, thank you so much for sitting down with us.
Thank you very much.
Yeah, we had a little opportunity earlier to do kind of a deeper dive into specifically obstructive sleep apnea, your stop bang criteria and assessment tool. But one thing that we didn't get to talk about, and I want to take a little bit of time to reflect upon, is the post-op respiratory complications, which I know that you're very passionate about and talk a lot about. I think as Monty and I are both anesthesia providers, and we have a lot of people that listen, a lot of anesthesia providers that listen. And so, I just want to talk to you and do a little bit deeper dive into, some of the risk for post-op complications and some of the things that we can do as anesthesia providers to help prevent those. So can you kind of address some of those things?
So I do think that at the present, respiratory failure and respiratory complications are not on the high radar of most of the anesthesiologists and the healthcare professional, because the cardiac risk and MI, they are the topics that really catch the attention. I do think that actually respiratory failure is almost account for 10% of the complication after, whereas MI may be 2 or 4%, or less. So I don't understand why we don't pay more attention to respiratory failure. And respiratory failure may be due to a number of reasons, and there are causes of respiratory failure which the anesthesiologists or anesthesiology providers have actually caused, which is,
we don't want to admit it, right?
Exactly, which is residue neuromuscular blockade, and we give the muscle relaxant, and the patients still have residue neuromuscular blockade, and they may not be adequately reversed, and then they are in the PACU, and then they may develop respiratory failure as secondary to that.
What do you think the incidence, or what do you know that the incidence of residual neural blockade is?
So to everybody's surprise, it's actually 20 to 40%.
Oh my gosh.
Yeah, so it is a very high incidence, and this is evidence-based.
But I guess it's probably not recognized because, you extubate somebody, they may seem out of it already just because obviously, the anesthesia, so we don't recognize it exactly. But how does it manifest? I mean, how's it been manifesting?
So a lot of the time, the patient, you can see the patient try to breathe. They may have shortness of breath. Yeah. They may fail. We always, anesthesia provider, we say, they can squeeze our hands. Yes. You can lift your head. But usually even within, they can do this. It can be 50 to 80% of the junctions still blocked,
yeah.
Right? So essentially, I do think we have to monitor this patient with neuromuscular monitors, and that we should be trying to reverse this patient. Personally, I do reverse every single patient, but there are anesthesia providers that don't reverse every single patient.
Yeah, that kind of blows my mind because I have of that mindset too, that I reverse everyone because you just never know how people are metabolizing and what, and we don't use objective neuromuscular monitoring in my institution, and so you just never really, you don't really know. Yeah. How many facilities here in the U.S. are utilizing objective?
So I do think that I practice in Canada, and I do think in our institutions, we do have the monitor in every room. We try to use it, but also there is a lack of very good monitor at the present. I do think that we need to work on that.
Yeah. I mean, I just think that people just don't know, how people are coming out and what the level of blockade is. So we talk about the different reversals that we have for reversing neuromuscular blockade. Traditionally we've always used the neostigmine and glycopyrrolate right? And Sugamadex is kind of the newer product that's come out. What is your experience with those?
So actually, I was one of the original investigators that actually test in patients using it in the phase 3 trial. And my impression is that it's really, really effective when we did the study. And one of the things that actually, the one thing that I noticed, these patients actually wake up very quickly. and I was not sort of prepared for it. And you have to make sure, wow, the patient wake up, they look around and then they say, whoa, this is very different from wake up from neostigmine and atropine. Then I look up some of the papers and it said, well, if the neuromuscular blockade is actually when it's blocked, there's no efferent, stimulations to the brain.
Yeah.
And when you reverse it completely, all these efferent response from the junction goes to the brain and the patient is wide awake.
So I've seen memes out on Twitter where it says, it'll have my patient on Sugamadex, and it's like this patient like going wild, sitting up straight, and you're like, oh my God, that's exactly the way it is. And then you start to think, wow, all these years I've been doing it, and like this is what my patient should look like, and then it kind of gets a little scary. I don't know, but some of those memes are hilarious. But that's true. I've used it in practice myself, and that's been my experience as well. There were a lot of questions. So you gave one of your presentations yesterday. It was on pulmonary complications and things like that. And you did kind of speak to residual neuromuscular blockade. And there were a lot of questions about Sugamadex specifically and some of the other, what we've been doing traditionally. And what was your biggest takeaway from what some of the delegates were asking? So
I think the delegates were very interested and they have a lot of experience in it, but they actually want to more assurance.
Yeah.
Right? How to use it and all these. They are using it, but they still want more assurance that they're using it correctly. Yeah. And I think there's a wide expertise among the audience. Yeah. And they're using it in many different ways. So I do think it is a very good drug that we should use it much more often. In North America, I don't know about in Europe and in South America and Asia, what is the cost? In North America, we do have a cost issue here in terms of that is priced very high. But still, being one patient who has respiratory failure and one day in the hospital and also the morbidity is very high. So the cost benefit maybe is still beneficial to use it.
Yeah. I did notice that there was a lot of variability within the audience of when people use it. And there are a lot of people that are, kind of very selective whenever they use it for OSA patients or obese patients.
Yes.
Yeah. Typical patients that don't reverse well. And we kind of know those patient populations, kind of get used to that as well. But I thought it was very interesting. I still hear that people are kind of concerned about like anaphylactic reaction. What is that?
So I think what happened is in North America, the FDA did delay the issue of Sugamadex being allowed to come on the market. And we actually is much slower than in Europe and in Asia and in South America. So we are a few years behind, and essentially they did more studies in it. Yes, there is an issue of hypersensitivity and anaphylaxis, and the incidence they quote could be as high as 1 in 200. I haven't heard of too many cases, but recently I heard of one case in which the patient did develop anaphylaxis so it is a potential. Just like muscle relaxant, like the pancuronium and the rocuronium, you can have anaphylaxis with it. And just like any drugs, like penicillin. So we have to be prepared for it. And if we know the incidence, then we are prepared. You know what to use, epinephrine, the usual treatment for anaphylaxis.
Yeah, absolutely. I like what you said. One, pulmonary complication, it's another day in the hospital. That's pretty profound when you think about it. If we have, and the risk of pulmonary complications, again, what we were saying earlier,
10%.
It's really high.
Very high, 10%. And people don't recognize it because I think it is actually under-evaluated and under-researched as well. Yeah.
Well, thank you so much for sitting down with us. I just wanted to have a quick chat about you because there was just so much interest yesterday during your session about it. I just thought we'd cover it again here on Top Med Talk. But thank you for taking the time.
Thank you. Thank you.
And we'll check back with you guys again soon. All right.
Okay.
Thanks.
Thank
Cheers.
you.
Bye.
Bye-bye.
Top Med Talk.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. ebpom.org/meetings.